Okay, so we're very excited to continue on part two of this PRH workshop on how to recognize when persons need medical care. Medical care meaning it can be mental health care or mental health related medical attention. Why do I focus on that? Because we're not going to talk about, say, for example, someone getting a headache or general other physical symptoms. Yeah, we're going to look at symptoms that are related to mental health. It can be a headache also, but a little bit different headache. Yeah, so that's why I use this title. So it is for PRH helping professionals, so we can do our work better by recognizing if certain people might need other support. Okay, so yeah, these were our. I'm not going to go back, but these are some of the objectives that we have. And we looked at this last week. We looked at how our bodies can and ourselves can be also seen from this perspective that we have a hardware, our brain's the hardware, our mind, the way we think and so on, is our software and the way we experience things. So our brain is not just our eye, even though we associate it with our eye, but a lot of our feelings actually happen in our brain as well, even though we associate it sometimes here in terms of our bodies, as well as the seat of our personality and everything. So it's quite interesting. Yeah, we sometimes position it in this way, but also the brain has a lot to do with it. And of course, our bodies, our entire body has an important role on how we experience ourselves within and externally with the relationships that we have. Okay, we talked about how this body is a biological dimension. And in medicine, we usually say biopsychosocial, sometimes with spiritual, depending on the perspective. So there are lots of things that can happen to our bodies. And when those things happen, they, of course, impact on how we think, how we feel, how we behave, our general experience of our inner world. We also talked about how our behavior and our brain, they're interlinked in different ways. For example, when people put substances in their body that can change the way we behave. And there are triggers that can make us want to do the same thing over and over, which is common in addictions, for example. But it doesn't always have to be substances. Sometimes there are activities, there are gambling, games, sex activities, or all sorts of different things that can become a pattern where our brain is no longer under our control. In a way, we're no longer able to decide so freely because there's this urgency, there's this craving, there's this movement towards seeking the thing that becomes the addiction, the source of addiction. Yeah, so we understand that. So addiction changes the brain, and then the brain in addicted people kind of fuels the addiction, so it becomes round and round and worse. But it is possible to come out, but it is a challenge because it's easy to relapse into this pattern. But PRH can do something, not specifically on addiction, but to give people meaning, which often can lead people into seeking something deeper. And when they are able to seek something deeper, then they are less likely to get stuck on something less deep, something more superficial. Having said that, a lot of times rehabilitation is needed so that people can actually detox the impact of those addictions on their brains and their lives and relationships and everything else. Okay, so we looked at the different categories of mental conditions. I mentioned the Diagnostic and Statistical Manual of Mental Disorders. We call it the DSM. At the moment, we're up to number 5. It's interesting how the DSM has grown through time. For example, in DSM-3, they didn't have anything related to trauma. So trauma wasn't considered to be a mental condition as such. But and then the DSM-4 recognized post-traumatic stress disorder as an entity which is already solidified in DSM-5. So we'll see. I don't know. The next DSM will identify new things. Who knows? But the idea is to have these categories. It helps people recognize what conditions they have. That is not to diagnose themselves, but of course with the help of professionals. So professionals can have the same criteria to determine if a person has a specific condition, and those criteria help inform treatment, whether people need medications or other things, as well as financial support in terms of insurance and all government assistance, or maybe support in schools and things like that. So it's quite interesting how important these criteria can be. But as I mentioned prior to starting this recording, people are people. So at the end of the day, it's not about their diagnoses, but it's about what they need as a whole, and how we as PRH educators have something to offer, and we can understand what people need, and if that suits us, that what we can offer is what they need, then we can help them, even though they might need other things as well. Well, we're open to those possibilities, and we can support them in seeking what they actually need, or in addition to what we can give. So these are some of the categories. I've mentioned them before, and we're going to go into more detail today with some of them. Okay, so there's so many. We can't spend a year, like even courses in university go one by one. They can't go on all of them. That's how many there are. But at the end of the day, as I said, they are people, and some of them have this and that and a combination of things. But at the end of the day, how do we support them to become more fully themselves? Okay, so these are the ones that we will look at, yeah? So we've looked a little bit at attention deficit hyperactivity disorder last week. We looked a little bit at psychosis. So we'll look at other things today. We'll look at mood disorders, anxiety, post-traumatic stress disorder. We'll have a little bit of an introduction and understanding of what personality disorders are, a little bit about dissociation. And the most important thing is we're not here to diagnose, of course. We'll get the mental health professionals to do that. We've got a lot of questionnaires, and I can give you the link to those questionnaires to help you just to be informed, but of course not to necessarily use them in a diagnostic capacity. Okay, so we talked about this, ADHD, how it is about a selection process, yeah? People, at any given time, there's so many things we can pay attention to. There's so much stimulus, but we have to choose. What are we going to focus on? What are we going to do? And when we are not able to do that, then we're all over the place, or we hyper focus. We have to really, really block everything out in order to be able to focus on one thing. So it's a challenging thing for people whose brains are what we say not neurotypical. Yeah, so they have a different way of functioning, and sometimes medication helps. Sometimes there can be different trainings, neurofeedback trainings. There can be different modalities like transcranial magnetic stimulation, all sorts of things. You don't have to know all this, but basically there are lots of different things we can do. Also, I mentioned how foods, substances that people digest and ingest can make a big difference in how people's energy levels and how they can function in their brains. Just generally speaking, it is recommended to avoid things like gluten, and sugar, and dairy products, and of course different colorings and genetically modified things. It is about getting back to nature and getting to know what our bodies need in order to help our bodies give the perfect balance of energy for our brains to function without inflammation, and that way can function well. Yes, here's an updated view of the different frequencies. Sorry for the mistake from before. As I mentioned before, the higher the frequency, the faster it is, the more we are focused or concentrating. But if it's too much, then it gives us a headache as well. Yeah. And when we're sleeping and when we're resting, we've got slower waves, and we need this balance. And in people with attention deficit hyperactivity disorder or attention deficit disorder without the hyperactivity, there's a different pattern in brain waves, as well as in other conditions. So actually, this EEG can be used for many different things, including even things like anxieties. We can see patterns and different sensitivities. We can see lots of different things in this, but it's not completely mainstream yet. Some professionals are using it and some are not. And it's not just medical, because it's available for other people to use as well. So a lot of holistic healers are using it. So there are lots of different controversies about how and when we can use it, and how to read it. Yeah. Okay. And so we looked at this. We looked at psychosis as well. We looked at psychosis as problems with reality, when we cannot tell what is real and what is not. And today I want to add a little bit to the issues of ADHD and psychosis related to when we are working as PRH educators. I'm going to share a little bit about cases that happen that are very important for us to recognize. For example, ADHD, we can notice that some people are just restless. That's an easy way, but it can be to the point that it disturbs other participants. So notice this. Notice, I think it's hard not to notice actually, but how do we position ourselves in that sense? Well, we position ourselves in that we are maintaining the peace, of course, between the different participants in a workshop. For example, if one is disturbing the other, whatever the reason for disturbing, whether it's a diagnosis or not, then we are going to be mindful of the group dynamic, of course. So sometimes we will have to take them aside and, have some boundaries or tell them to do things. At the same time, we recognize that people with these conditions, both those with ADHD, for example, they need a special consideration. So I suppose if some of you are used to, working in schools or just your experiences of in schools, sometimes there are people with special needs or, special requirements in schools, then we kind of try to see what we're able to provide or what we're not. And when we're not, of course, we'll have to say, let's do one-on-one for you. I don't think group activities would be good, because we're mindful of the entire group. Things like that, yeah. But sometimes some of them need things like stimulation. So when they're holding something or they're doing something, then it helps them. Make sure that they're not making too much noise, because that sometimes happens. A lot of them are on their gadgets a lot, and they don't mean to be disrespectful, but they're bored very quickly. So having different things to get them engaged might be important. With psychosis, we've had this experience as well, where people, when they are not comfortable, they will seek ways to feel comfortable. And a group on personality and human relations, okay, that might be something that they look for. Now, one thing is, because it's hard for them to recognize what is real and what is not in cases when they are psychotic, then we need to be mindful when they talk about sensations. Are they real or are they not? Technically, sensations are subjective, so they should be real in that they really experience it. But once they, for example, hallucinate and they say, oh yeah, we feel things, but then if we feel actually, I don't know, ants crawling around us and we think that they're actually there, or we hear voices, that sometimes happens. Someone might be in a time for being, for example, and we have those moments of the being that can be of sound. Yeah. So how do we differentiate? Well, one easy way to differentiate is that it's not helpful for the person if it's psychotic. Yeah. So people hear things like, I don't know, Satan talking to them, or calling their name that makes them uncomfortable. Well, that's not going to be something from the being, of course. But sometimes it might seem like it, especially if someone is manic and then they're feeling like, oh, I'm elated, God is speaking to me. And some people question whether this is I don't know, a spiritual thing or not. Usually our easy way of differentiating is this beneficial, and is this something that adds to their social function or not? Because in some I suppose some cultures, spirituality is manifested in different ways. And, I don't know, deities or spirits talk to them, but they are socially functioning well. But if they're not socially functioning well, then it might be something else. And one thing I usually do is, send them to get it checked to a psychiatrist. And one thing I do is try the medication. If the medication makes you feel better and makes things go away, then probably that's it. Because nowadays some people think they're indigo, they can feel things, and maybe some people can, I don't know. But the difference is whether it's helpful or not for them. So that's an easy one. Not an easy one, but a way of sort of delineating whether it's something that requires more attention medically or not. Okay, so today we're going to go into a little bit more on mood disorders. So just now I already mentioned that, for example, someone who's in a mood episode, yeah, can also become psychotic. Yeah, psychotic means what they believe in or what they experience is not necessarily real. And there are different types of mood disorders. But generally speaking, we divide them into two. One is bipolar and one is not bipolar. As simple as that. What does it mean? When someone has a bipolar condition, it goes extremes, up and extreme down. So that's the difference. The other one, which is not bipolar, or we call it unipolar, is not ever going up. So they only get depressed. This is very, very important to differentiate, and even the psychiatrists sometimes get it wrong. Because when people come with depression, we don't always ask them whether there are moments when they're up. And people like being up most of the time, yeah? So people are not going to complain about being very happy, even though they're happy for no reason. Or they are not going to say, necessarily complain when they're overly cranky, because they're always going to find reasons to be cranky when they're at that up stage. So bipolar, when they go up, it's not necessarily a happy phase. It can be a very irritable phase as well. But basically what we're saying is too much energy and too little energy in the depression phase. Yeah. And so it's sort of like episodes. The people can get episodes where they have a lot of energy, they don't need sleep, they can do a million things and a lot of productive things, very creative and so on. And then there are moments when they can't do anything. It feels like they can't even get out of bed. They can't think, they can't do basic self-care, they don't feel like eating, they don't feel like going out. So there are these sort of extreme episodes. And so when that happens, people need to be treated in what we call mood stabilizers, because what they need is a stabilizing condition. And so it's an electrical thing, I always say, because the brain is hardware, right? It's electricity. So sometimes the electricity surges up and surges down, and that's what happens. And so when we give people mood stabilizer, it's basically like a UPS. If you have a computer and you have the UPS to stabilize it, it's a stabilizer, and that goes to the electrical system. Here in Indonesia, we still have power outages in certain rural areas, remote areas. There's a lot of power outages in the islands, for example. Then we need a UPS to help us so that, when the electricity goes out, our computer doesn't just go out with it, right? We have sort of that backup that saves us time to save our work and things like that, for example. So the same thing is happening with the brain. When we give people mood stabilizers, people are less likely to have those extreme episodes. Interestingly, mood stabilizers are commonly also anti-epileptic medications. So again, it is similar. Yeah, they have episodes where they are moving uncontrollably. That's what happens in a lot of epilepsy, or just not moving and sort of like zoning out. That also happens in some epilepsy. And so what we say is, mood disorders like this, the bipolar, is like epilepsy for our mood. Yeah, that during those moments, it's just like going haywire. Your mood goes haywire, either up or either down. But like people with epilepsy, most of the time they're absolutely normal. So if you see someone and they say, oh yeah, I've got bipolar, can I go and participate in PRH? Well, if they're not in an episode, they're absolutely normal. So it would be a discrimination if we are not accepting them, because they want to grow also and make good of their lives, and to deal with the repercussions of those episodes, because it can be very terrible for them. You know, during the high moods, maybe they're very happy, but they can spend everything. They can lose all their money, for example, or they can go into relationships that are dangerous, risky behaviors, and that kind of thing. And when they're depressed, of course, that also can be very unpleasant. So there are repercussions for that, which then they have to, sort of manage their life. So they need help. Sometimes we can help in those areas, even though they will need treatment from a psychiatrist. So that's bipolar. Notice here, there's mania, which is the up part, and then there's hypomania. That's interesting. I think this is important because when people have hypomania, it doesn't seem like it's a problem, because they're just having extra energy. Yeah. And we find this a lot, interestingly, in people like artists. Yeah. Because then they're like, they're the boost of creativity. It's almost superhuman. It's almost like, wow, how could you do all that in such a short time, and so on. Yeah. Because it's very, very can be very productive. They can be very productive. But when they're already manic, they're not very effective in the productive way. So they do a lot of things, but they're not finished, or they're a bit like, what are these ideas? They're a little bit strange, things like that. But when they're hypomanic, it can be very still within normal function. So it's just something that people might like. And because people usually like it, especially if artists, some of them say they cannot produce their work unless they're in a hypomanic state. So which makes it difficult, because then they don't want to take their mood stabilizers, right? Because they're saying, if I take my mood stabilizer, I just become a normal person. I can't produce all these amazing things. So they can't do it. So what they do is they sometimes come on and off of their medication, but we have to understand why they do that. And then when they get depressed, that's a problem usually, because in what we call bipolar 2, bipolar 1 is the one with the mania, the extreme high. The hypomania is bipolar 2. The depression gets really, really bad. And when people are depressed, it's a very, very high risk. Why? Because people do end their lives. So if we can, see this as an emergency situation, we can save lives. We really can. And it's also interesting. So that in either bipolar or not bipolar, anybody who's had depression, when people are very, very depressed, they can't do anything. They're like, I can't get out of bed. I can't do anything, And there's one telltale sign that it is depression. They cannot enjoy what they usually can enjoy. Yeah. If they already lose that capacity to enjoy the things that they usually enjoy, we call it anhedonia. It's a very sad condition that we need to help them, because otherwise it's very, very hard for them to get out of depression. Also, because when people are depressed, also they tend to isolate themselves and remove the life-giving relationships that they have. So it makes it even harder. And as I said, they can be not fully psychotic, but sort of like thinking things that are not very rational. Yeah. For example, that, there's no use for me to be alive anymore. I'm a burden to my family, or, oh, this guilt, I can't bear with it anymore. And that can push someone to ending their life. Suicide is real, and it's something that we are mindful of, not just as PRH educators, but in general, the whole population. There's so much we can do to save each other in this sense. Yes, and I have had moments when I've been able to rescue people from those moments, but it's not always in my practice. It's just noticing people who are like, they seem a little bit lost. I find them a lot in university after big tests with poor results. Yeah, we need to make sure that people don't do extreme things during those times, or people who lose their jobs, or people who lose their important relationships. Sometimes they feel overwhelmed and they feel like there's no way out. That's a little bit of that irrational thinking that happens. It's also important to notice that this when people are very, very depressed, they don't have any energy, and then if they get medicated, then they get energy. That's a danger time. So if you notice, antidepressants have a black box warning that it can increase the risk of suicide. It doesn't make sense, right? Why would someone have increased risk of suicide when you're giving them antidepressants? It doesn't make any sense. Well, there are two reasons. One is, first, their energy comes up, but their way of thinking is not yet fixed. So they have energy to do things. Before, when they couldn't get up, they're not going to kill themselves because they don't have the energy for it. But when they have energy, but they still think that they're useless and whatever their negative self-image tells them, then they might actually have the energy to do things. So this is very important for us to actually make sure that people are accompanied during this time, just by checking in on them. How are you? Are you okay? And that's usually enough. And to actually ask them the question. Usually people are afraid of asking the question, do you ever think of ending your life? But it's actually a screening question that is essential and can save lives. Why? When people can talk about it, yes, actually, I've been thinking of death. I don't know, it's been on my mind. And then they can talk about it, then it relieves them, right? It's hygiene of the sensibility. And then they're not alone in this very, very scary moment in their experience. So when they talk about it, then they're less likely to actually do it. And another thing that we're very strong in, which we are actually teaching other people to do, is to help people identify people's strengths and people's life-giving relationships and the supports that give them meaning in their lives. So people say, oh yeah, I feel like killing myself, but I've got to take care of my cat, for example. Okay, then we're like, okay, you take care of your cat. Tell me about your cat, how much you love your cat. Yeah, someone else can take care of it, but it's not going to be the same as you. Yeah, you have this very special relationship. Then they're alive because of their cat or because of their cactus, whatever, but it keeps them alive until the moment when they realize again that their life matters. So going through those important moments is very, very important. So that's a little bit about that. Okay, so here's again bipolar disorder. So it usually comes up in the young. That's the same as psychotic conditions, actually. So psychosis in schizophrenia, that comes up around 16 to 26 years of age for males, and a little bit later for women, maybe around their 20s, yeah, and early 30s. So a lot of families, they say, oh, they were fine when they were kids, they were fine, and then suddenly they flipped, something happened, maybe they couldn't handle things, they thought things like that. But it is because somehow that's when the brain starts having those problems that manifest as symptoms. Having said that, there are some people who with already schizotypical, we call it, signs or symptoms or presentation from childhood. They may be a little bit strange. Their friends can't really understand them very well. They're maybe a little bit aloof. There are some cases like that, so it's different. But genetically, interestingly, both bipolar and schizophrenia has very strong genetic components. So, and they can be interlinked. So there's also conditions called schizoaffective. We don't use it very much very often, but so psychosis, bipolar, and so on, they can be sort of in this group where it's a little bit complicated. Get the professionals to understand. But so yeah. So these are some of the things. If someone comes to you and then speaks non-stop very fast, wait a minute, this is strange. Okay, they're not sleeping, wait a minute, that's strange. Yeah, they're jumping from one idea to another idea, it might not be ADHD, because ADHD happens all the way from childhood. This one suddenly appears later on, yeah, and it's episodic. After that, they're not like that anymore. Yeah, so that's the manic state, and then it's a depressive state where all of these conditions, they can be irritable, but the irritability can be different because both conditions can be irritable. One is irritable with a lot of energy, and the other one is irritable because I can't stand that. It's just a little bit lowish irritability. Yeah. So so there are lots of different signs and symptoms. Don't worry about them so much, but generally speaking, just see their energy level and whether that's something that might require additional attention from medical professionals. Okay, so just now we talked about this unipolar depression. What is that and how is that different? Well, that's a condition which I must say everybody can suffer. Yeah, not everybody can get bipolar. That's, as I said, there's a genetic component. Not everybody's going to have a risk for schizophrenia. Some people absolutely don't. But everybody can suffer from depression. Some people have a greater risk than others. There's a genetic component. If the parents are depressed and the relatives are depressed, it's more likely. Also because if you're in a depressive household, it can be very depressing. So whether it's genetic or whether there is also environmental component, it's also. But people can be depressed because it can be too much. Life can just simply be too much. And when life is too much, then we get sad. And when we don't find meaning in our lives, it's sad. When we have no life-giving relationships or we lose them, it's sad. So people can become extremely sad, not just normal sad. Everybody gets sad. And when they meet a certain criteria, they can be depressed. Interestingly, depression and anxiety are, sort of siblings, I suppose, or they have this a strong overlap where even the neurotransmitters in the brain are fairly similar. There are some differences, but fairly similar. And actually, the treatment is also fairly similar. So we use antidepressants, not just for depression, but also for cases of anxiety. Because that helps. There are different types of antidepressant, that is, and let the professionals think of that. But basically, when people are, I don't know, I'm not sure, that can also be a part where, they can be a mix of depression and anxiety, for example. Yeah. Or people who are very, very anxious and then they can lose energy because they're too anxious and then they don't get out of bed and then become depressed. So it can be sort of a combination of different things. So yeah. I think everybody can be anxious, but not everybody has an anxiety disorder. Again, that goes back to that DSM. That's why the professionals, they will look at whether they meet a criteria or not. Everybody's anxious when they have to do something that's important and has an important risk, for example, because in a way worry or concern is a part of the human experience, and we have this experience to help us get ready for things. I suppose when people are never nervous, then we kind of wonder, are they really prepared? If you have, I don't know, children or students who don't care that tomorrow there's a test or don't care, then you're like, we'd like them to care a little bit and, do some of the work, for example. Yeah. So it kind of, there's this borderline where when we're aroused, we can be a little bit anxious or not. And interestingly, it's also related to how we perceive this increased arousal inside us, because some people are adrenaline junkies. Things that would scare the hell out of certain people, they enjoy, jumping out of airplanes or, doing crazy stunts or whatever. Some people love it. Some people love speaking in public, and some people are scared absolutely will not do that ever. So there are different degrees and different perceptions of how people experience this different arousal. And some people get very, very anxious for very, very little things. So there are different types of anxiety disorders. Some are specific, like phobias. They're very scared of certain things, but there are some that are anything and everything worries them. They're worried. There's this free floating anxiety, we call it. They're worried about everything. Well, we need to help them, otherwise it can be very uncomfortable for them. And there are medications and treatments that can help them. So do see if they're already too anxious, maybe they need extra support. Okay, so one very, very strong anxiety symptom is a panic attack. Maybe some of us have experienced it. It's a terrible situation, yeah, when our alarm bells just go nah, 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 and then we can't think anymore, we can't do things. Our whole body might experience different symptoms. It's not pleasant. People don't like feeling panic, yeah, but people use the word panic for simpler things like, oh my goodness, I got a phone call from someone, and then they're sort of panicking, when actually it's not really a panic attack in the medical definition, of course, but it's a word that people use. When people do have a real panic attack, it's very uncomfortable, and they usually really, really feel grateful when they get the proper treatment. And a lot of them, they carry the treatment with them in their, wallets or in their pocket, in their purse, because just in case if anything happens and they get a panic attack, then they can take it. And sometimes they don't ever take it. They just keep it in their purse, sort of like as a security blanket, yeah, to know that they're not going to lose control during those moments. So there's panic attack and there's panic disorder, where people are worried about getting panic attacks. Then they're like having this anticipatory anxiety. Oh, what if I get a panic attack? And they're all worried about that. And so we treat that also. So there are different ways of treating that. Yeah. So some people just have panic attack just once and that's it. But because it's such a scary thing, some people then get worried about having extra panic attacks. Okay, related to that, there's also trauma. This is a bit tricky. As I said before, it's a new addition to the DSM-4. It's already established in DSM-5. So what happens to our brain when we are traumatized? Well, something does happen. What happens is we have a part of our brain that detects danger and responds to danger. And this is a very important part of our brain. Otherwise, we would not be here. Our ancestors would have been killed off by, lions and all that, and crocodiles. But the fact that we're scared of snakes, for example, is, it's sort of like, oh, because it tells us that thing can kill us. So it's an important part of who we are as organisms that need to keep ourselves safe. Unfortunately, when we have terrifying experiences, whatever that is, then our alarm gets hyperactivated. And when they get hyperactivated, we have to go through a process in order for it to be normal again. It's a bit like your smoke alarm is ringing and then it just keeps on ringing even though there's no smoke or whatever. Then it's useless, right? A smoke alarm is useful when it's supposed to do its job, which is when there's actual danger. So we need to recalibrate it. And that's sort of what happens. And when people have severe incidents, say, they almost lost their lives or the lives of their loved ones, for example, can be very, very scary. Even if it's once off, then it's sometimes that alarm keeps going. Sometimes the trauma is not a once-off thing. It can be a traumatic childhood, for example. Or what do we do then? That it becomes a little bit complicated. We don't necessarily put it in the same category. We say it's a chronic or complicated situation. Now we have, it's like a complex PTSD, they call it, yeah? Complex PTSD, because it's not just one incident or a certain, say, for example, earthquake or, bushfires, wildfires, that kind of thing, but it's a whole, years and years of experiences in their family, for example, then it's a little bit complicated. But people, might suffer from abuse in that way, or sexual assault that's repeated and things like that. So very, very terrible things can happen to people, and it does wreck their brains, unfortunately. And so what happens when the alarm bell goes on too much? Well, people can re-experience it. So when the alarm comes back, it's like it's happening all over again. Very, very uncomfortable, of course. Yeah, they can be frightening for them. It's like not just dreaming, but actually like being there. People talk about being at war, and then they're already in peaceful times, but it's suddenly like war. And this is what we see a lot unfortunately, in cases in the United States, for example, where war veterans, and in the United States, arms are available. People have guns and so on, so they do use them, and then they feel like they're in the middle of the war, and they might shoot people who are not their enemies at war. So that's a bit sad. That can happen. Another case would be hypervigilance. So maybe they're just scared all the time. It's like they're, under threat when there's nothing there. And avoidance, because then they say, oh my goodness, it's so uncomfortable. Every time I go to that place, say, for example, the beach after a tsunami, I remember it again. So I'm not going to go to the beach, which is fine if you don't need to go to the beach. But if you're a sailor, if you're a fisherman, that makes it very difficult. So we need to do something about that. Yeah. And then emotional dysregulation, sometimes it just feels extreme. It suddenly cries, suddenly outbursts, and so on. So that's something that happens in people who experience these things. Okay, so what can we do in these cases? Right? Well, of course, they need professional help, but a simple thing is to help people relax. So when people are relaxed and they feel safe, then it's good. Having said that, for some people, just the thought of relaxing is already scary. Yeah. So you have to look at the different cases in different ways. But for some of them, feeling safe, yeah, in a group, feeling safe, in being accepted, it helps a lot. And it's a very physical thing, as I said before, with the book, Bessel van der Kolk, The Body Keeps Score. It's recorded in our bodies. Our experiences are recorded. And what happens is the shoot in adrenaline and cortisol and all that during those stressful moments, they're recorded. And sometimes they replay and, all that. But the one thing that we can do is breathe. As simple as that, but as powerful as that. We cannot control our heartbeat. Well, maybe some people who are very, very good meditators and so on, they seem to be able to, but usually it's through the entrance of the breath. Because when we breathe slowly and regularly, what happens? Everything else in our bodies follow. So just practicing this and helping people practice it. I know we do it in our time for being, for example. We can add it to the exercises during our workshops and so on. Very, very useful. Yeah. And so the idea is like this. When we're stressed, we breathe shallow and fast, right? We go like that. And what we want is the total opposite, which is slow. It doesn't have to be deep. Some people say deep breath, deep breath. It doesn't have to be deep. It has to be sort of smooth, a bit like seamless. So if you can hear your breath, then it's still a little bit too strong. And what I do is there are lots of different YouTube I have here, and you can have a look at them later on. But the idea is it's this connection between our bodies and what we can control. And our breath we can control, but at the same time, it is independent. So isn't that amazing? Like our hands, we can control, of course, but it is not fully independent in that our hands are not going to move by itself unless we tell it to. But our breathing, it's going to happen whether we tell it to or not. So there's this interface between what the body independently does and what we can consciously control. And so when we breathe slowly and regularly and very, very gently, simply gently, then magic occurs. Something happens where we can feel really, really connected with ourselves. Yeah. And when I, invite people to breathe, one of the things I do is, firstly, get them to just pay attention to the breath. Just starting from that, pay attention to the breath, how the air comes in, through our nose and then all the way into our lungs and so on. Interestingly, the most effective breathing gets help from our diaphragm. Our diaphragm is the muscle between our lungs and our abdomen. Yeah, there's this diaphragm. Now, when we breathe, we can use our diaphragm or we can use the other muscles in our chest. And if we use the other muscles in our chest, we go like this, right? We go like that. And we use all those muscles. That's a lot of muscles. And that's a hard work to, open our rib cage and everything. It's a lot of work. Yeah. When we use our diaphragm, it's just one muscle. We're one muscle, and we lower our diaphragm by bulging out our stomach. When we bulge out our stomach, our diaphragm gets pulled down, and then we release it by simply releasing the bulge of our stomach. Yeah. And when we do that while breathing, breathe in, feel the bulge in your stomach, and then release it. Yeah. It's a bit like baby breathing. If you notice, babies do that. Yeah. Their abdomen goes up and down. Not this. And that's why I say don't deep breathe, because when you deep breathe, you usually use all that. Yeah. It's a lot of energy, and then you kind of hyperventilate. And that's something you totally don't want. You've seen it in movies. People then breathe into a bag. Why do they do that? Because when we breathe too much, we have too much oxygen and too little carbon dioxide. And believe it or not, we need a balance. And we need enough carbon dioxide to help us function. Otherwise, what happens? We might get tingling in our fingers. We might actually have like a little bit of a our hands become hard to move and things like that. We can feel tingling all over, and then we can start getting a panic attack and all that. So we just need to just breathe gently. And when we just breathe gently, you know what I love? We can breathe with our whole body. Just really picture it. Picture that you're not just breathing with your nose. All of the cells of your body are breathing. And you know what? It's true. It's true. All of our cells have to breathe. They have this oxygen, carbon dioxide interchange, which is they're breathing. Of course, they're not breathing the same way that our lungs are, but they are. And when we really get in touch with that and say, look, I'm going to feel my whole body breathing. It is a beautiful, beautiful, wonderful experience. So it's not always easy, and some people get restless and all that. So you have to play it by ear. Yeah. That's breathing. And the second thing is progressive muscle relaxation. This is actually another simple technique. You can look at it, and perhaps we can even try it. Okay, here's the concept. If I tell you to relax, what do? Okay, you try to relax. Okay, relax. It's a bit difficult though to just relax, It's not that easy, right? What if I tell you to not relax, but to actually move, sort of like use your muscles to really, really, not fight, but make it really strong and harden your muscles. You can do that much more easily than saying relax, right? So let's try it. Let's try it with our hands. Yeah. And now imagine that you grab, you have something in your grasp, you have something in your hands, and you really, really don't want to let it go. And it's heavy. So you're carrying it, and you feel it, you can even see, you can feel it, right? It's heavy, and you can feel all your fingers and your hands being really, really hard, and your muscles getting tense and hard and all that. Yeah. You feel it. Yeah. You feel that. Yeah. And maybe you can count while feeling it, 1, 2, 3, 4, 5, 6, 7, 8. And now release it. Now release it. Now release your fingers from your, grip. Yeah. Release your arm. You can put it down. Yeah. And let it there. And then can you feel the blood maybe flowing in your fingers and your arm? Yeah. And feel that. Now that's relaxation. We can only really know relaxation after we tense it up. Yeah. So we can do this throughout our bodies. So not just our hands, yeah, but that's a good example. You can start with our hands, and then you can feel the relaxation. Feel it. 1, 2, 3, 4, 5, 6, 7, 8. Okay, so we can use numbers. We can count like that to 8, or we can say affirmations like, I am here. I am me. I am safe. Oops. Any affirmation, things like that. And it's really, really helpful. So the other part that I like, we can do our hands, we can do our bodies, we can do all that. But the one I like is our head and face, because that's a little bit tricky. So let's do this together. I think it's a good exercise. So we can just put it on top of our head. And then it's like our hands is weighing down our head. Yeah. So we just let our neck sort of carry the weight, and our head to carry the weight of our hands, and then pull it down. So our hands is even making it even more heavy for our head and our neck. And then while our hands and arms are doing that, get our head and neck to fight back. So we have this conflict, right? A conflict between our hands wanting to pull it down and our head wanting to pull it up. And we have this tension in our neck and our head. Oh my goodness, there's a lot of tension. Okay. 1, 2, 3, 4, 5, 6, 7, 8. And then you release your hands, you release them gently. Keep your head down and then feel it. See, you feel there's something light in your head. And then you just lift up your head like that. Can you feel it? That can be very, very relaxing. Yeah. And you can do this anytime, anywhere. It's really good. You can do it on to the side, and so on. Yeah. I love it. So it's one thing that I love doing with my clients, with my patients. Yeah, we can do it with everyone, with our family, whoever, ourselves. And what do we do with our face? Now, this is also an interesting one. How do we tense up and remove tension from our face? Well, I love doing this with kids. They love it. But also adults, we make a terrible face. So what do we look like when we're stressed? If someone's on Botox, they wouldn't be able to do this though. So you scrunch up your face like, oh my God, you're thinking about a million things. You're scrunching it up. You're scrunching up all of those muscles. When you're frowning, you're using a lot of muscles. When you're smiling, you're using very little. So just all this. It can be a very entertaining thing looking at people with scrunched up faces. So you scrunch up your face. 1, 2, 3, 4, 5, 6, 7, 8. And then let go. Let go of all that, and you can do a little bit of a face massage. I love face massage. Yeah. Do a little bit of that and say, oh my goodness. You know what? I think that's better than Botox. Because you're actually allowing those muscles to sort of contract and then release. Yeah, it's a contract release thing. Okay, so we'll stop there before we go to the next bit, just in case you have questions or anything like that. Okay, so I'll stop recording just in case you have questions that are private. Okay.